Okay, so you can go ahead and take your seats. We'll get started. Thank you all for being here tonight. I think many of you know me, I'm Wendy Chung. I'm a medical geneticist here. And we've got an all-star lineup for you. I have to say, all women, number one, and all women who are dedicated either to research or to care for others who have BRCA1 and 2 mutations. And just make sure you're in the right place. This is that meeting for women and their family members with BRCA1 and 2 mutations. What we were hoping to accomplish is that for many of you, we've seen you in the past, but for some of you, we've seen you actually a lot longer in the past. And so many exciting things are happening and changing, and we wanted to make sure people had some up-to-date information. And to the extent that you wanted to, you also have the ability to be able to reach out to others. And so tonight, we're going to be going over that. We are trying to cram a lot of information into a little time, so we're trying to give you really the headlines within things. So we're going to have time at the end of the evening for question and answer. So we'll have a panel discussion. After each of the talks, we'll have time for, we'll see how it goes for 2 or 3 questions. And then at the end of the evening, you'll probably have questions where you want to synthesize and put things together. So we're all going to come back to that. Okay. So the one other thing I'll say is that Force has been with us tonight, or Force is with us tonight. And so they've got a great table out here with lots of information. They're an incredibly valuable resource, educationally very, very good information that you can trust in that. And then also you'll see a table out here for the Breast Cancer Family Register, and Mary Beth Terry, who's the investigator leading that study, may have something to say about that as well. And then finally, I just want to call out for all the amazing people who made tonight happen and put it together. You see where my team is, Diana, Anna, Leah, Alana, and I thank you all for everything that you've done. Okay, so without further ado, I'm going to give you a brief update and refresh your memory about these BRCA1 and 2 things. So to remember that for those of you who have BRCA1 or 2 mutations, this is something you're born with, and it doesn't necessarily equal cancer, but it increases the risk of cancer, and that's what we're all here to think about. This is kind of like, many of you have actually heard me use this analogy, this is kind of like the brakes in terms of being able to stop your car. One of them is kind of the foot brake that you put your foot on, and the other is your emergency brake. And when you were born, you were missing the emergency brake. You still have the regular pedal brake that you could use, and you could slow down cells from being able to grow too much or grow too fast. And as long as your foot pedal brake works, that's perfectly fine. You don't have cancer, you don't have to worry about cancer. But as we all age, and unfortunately we do all age, but as we all age, there can be something that happens to that other brake. Either something happens to your brake pad, something happens to your brake line. But if you lose that brake, that's where the cells start growing and start going along that cancer process, and that's what we're here to try and figure out how to prevent, or at least recognize it early. So by the numbers, what are the numbers like? The numbers, and you've heard either Angelina Jolie or me or some of the genetic counselors say these numbers, but the point is that there's quite a wide range of numbers. And so, for instance, for BRCA1, as we talk about the range of risks that have been associated with cancer, really wide ranges in terms of various different studies. All of these are legitimate, but they have certain inherent biases in terms of that. And then a wide range of risk for BRCA2. And we're going to talk, I'm going to talk a little bit about that variability, because not all of us are not the same within this. So I know this is kind of complicated, but there are things that people know me, have heard me talk before. There are things that are genetic! They're really powerful genes that have a big impact. And other things that are genetic. You know, they're genes that still have an impact, but they don't have really the force. They don't have nearly the impact. And that's what I'm trying to show you here. BRCA1 and 2 we think about as being these more powerful genes. I promise I won't yell at you anymore. And those more powerful genes that have a bigger impact, but they still interact with all the rest of our genetic information. Genes that may have a moderate risk, genes that may have a smaller risk. And it's really the composite of all of that together that determines for any one of us what that risk of cancer is like. And it's hard because before,
I dare say, for any of you that have had your testing, with me even, all we've done is we've given you this part of the equation. We haven't given you this part or this part of the equation, and I'm not going to give it to you tonight, but what we're working on and what a lot of things like the Breast Cancer Family Registry are working on is trying to get this fuller picture. It's not all about the genes either. The genes are an important piece of this, but it's actually a lot of things that we've been exposed to over our entire lifespan, and it probably goes all the way from in the womb to in the grave, whatever those exposures are over a lifespan. So I'm going to call these things genetic modifiers. That is, they modify, they either increase or decrease the risk for BRCA1 and 2. There have been studies that now, this is not just a sort of conceptual thing, this is real. We do understand on a research basis at least what some of these genetic modifiers are. It is not yet, I will warn you, ready for prime time. So don't call me tomorrow morning and say, okay, I want that modifier test. It will be coming, and I expect in the not too distant future to be able to tell your risk across some of these spectrums, but we don't have it as a test where we can just draw your blood tonight and send that off, or spit in a cup and send it off. But do stay tuned, and that was part of the message I wanted to get to you, is that do stay tuned if this is something that you think about or would be helpful to you. Okay, so let me make this very, very concrete for you. And if anyone's really interested, we included some references here for those of you that are like real aficionados and want to read the primary literature, you can do it. But let's take, for instance, one of you in the room may be a woman at the age of 40 with a BRCA1 mutation. What I'm showing here in black line is over time. So this is age on the x-axis, 30, 40, 50, 60, 70, 80. And then this is what the risk is of breast cancer. And it's cumulative, right? As you get older, that risk continues to rise. And for the average woman with the BRCA1 mutation, this is what that risk looks like. And you'll see by the age of 70, 80, it's about 50-50. About 50% of women with the BRCA1 mutation would develop breast cancer. But what you can see is that there's a wide range. And so about 2/3 of women are between these dotted lines, and about 95% of women are between these blue lines here. But there are some women that at the age of 40 would have a risk of 20% of breast cancer, and some women down here that at the age of 40 would have about a 5% risk of breast cancer. And that's true if you wanted to take the slice at the age of 40, 50, 60, 70. The point being, in terms of thinking about this, is that these are decisions, how you deal with your risk are decisions, in my opinion, that probably or could change over your lifetime, right? You might make a different decision about what you might want to do about your risk when you're 25 than when you're 55 within this. And so what I hope we're getting to, precision medicine is something that I obsess about. So we're trying to be more precise about for any one woman what these risks are, because again, if you risk at the age of 40 were 20%, you might make one decision than if your risk were something like 5%, or if you go at 50, 60, 70, 80. So the future of what we're trying to get at is this type of test that we can do to be able to refine these risks more. So this is just showing you, this is that same plot again, sorry to confuse you, but this is the breast cancer plot, but here's the ovarian cancer plot over here. And I just want to remind especially the young women in the room that when we think about ovarian cancer, so thinking about ovarian cancer, which is tougher because we don't really still, much to my chagrin, have good ways of screening for ovarian cancer, that risk I don't want you to get freaked out about when you're down in your 20s or even, I would argue, into your early 30s. That risk is not very high. Really, you're going to hear much more about this later on this evening. It is something, though, I think for most of us after the period that we finished having children, just naturally it kind of happens that way, that's when that risk starts coming up. But again, these risks range quite a bit. If we get to the point, which goodness gracious, I hope we do, where we actually have a blood test where we can check for ovarian cancer, then I think all these women are going to be getting that blood test. But right now we do something relatively barbaric, no offense, but we yank out your ovaries, right? And that's a very effective way, as you're going to hear, but it would be nice if we had some other choices. For BRCA2, the story is mostly the same, but the risks overall are a little bit less. That's kind of the take-home message for those of you who are BRCA2. I do want to show you just a slight difference in the curves. For BRCA1, you see how this sort of starts to flatten out as women get older. For BRCA2, you don't see that kind of pattern. You kind of see that that continues to increase even as women are getting older, and that tends to be the pattern that we see. And again, when you think about where this age is, I want you, by comparison, look at how nice and flat this is through the 30s and even mostly through the 40s. So for BRCA2, you've bought yourself a little bit more time when it comes to the ovarian cancer part, but as you're starting to hit menopause, then those numbers go way up. And so it actually ends up working out about right. When you don't need your ovaries, probably you can get rid of them in terms of physiologically not needing them, and then when that risk goes up. So with this, for those of you who have already had a cancer, I just want to remind you, doesn't mean it can't happen again. It's not necessarily that it's one and done. One of the things that always bothers me the most is for women who have been there and done that. I don't like seeing them go back and do that again if they, unless they really had a great time the first time around. So we do want to be vigilant in terms of that, and that risk can be high. It can be up to a 50-50 chance, basically, of having another cancer at some point in your life. And again, the sort of earlier you've had, the younger your age was when you had that first cancer, you've got more time ahead of you when you could potentially develop another cancer in the future. So just important for us to be vigilant. I'm just going to very briefly say this, and Alana actually will probably say more about this. Insurance coverage is still good for this. So for any of you, and I'm talking maybe either for your children, your family members, insurance coverage is good for this. It is under Obamacare, the one genetic test that's covered for everything, so don't worry about this. The one exception of this that I still don't like is if you have Medicare and you don't have cancer, we're still trying to work on that part of it. But otherwise, I think we're doing pretty well. And I'm just going to summarize by saying that for those of you that are worried about genetic discrimination, we do have federal laws in place. We do try and do everything we can to protect you in terms of this, but feel free to sidebar any of us afterwards. But we are really advocating to make sure this doesn't come back to bite you. Okay, so let me just briefly then see if there are any questions, but otherwise the main thing I want to do is get to our fabulous speaker lineup for the rest of tonight. So any quick questions? Go ahead.
When you mentioned higher risk for a type of second cancer, what kind of cancer? Anything or
Yeah.
pertaining to?
So it's mostly breast and ovarian cancer, so it's still mostly those two cancers. And just for a very brief reminder, for BRCA2, much more than BRCA1, there is a sort of other cancer spectrum. So skin cancer, easy one to be cautious about in terms of minimizing sun exposure. For men, prostate cancer. So for any of you guys out there, prostate cancer is something that come with that, or even men with breast cancer. Pancreas cancer, thankfully, is not very common, but it is one of the ones that's more deadly, and we do have improved methods of screening for that. So those are the main ones that we worry about. Yeah, go ahead.
Is there a difference? I think, I don't remember which one is, but one of the ones had an AG delete something and another one was different.
Yeah. So what you're alluding to is that there are specific types of mutations or specific genetic changes. So there's one that's very common. We call it 185 del AG, which is maybe what you're thinking about. So. Yep. And so there are some of them that are more common that we see across many, many individuals, especially if you happen to be Jewish. There's some that we see lots in that community. Really what matters, though, is that for most of these, they have the same effect at the end of the day, which is instead of having those two breaks, you've got just one of those breaks. And either way, no matter what your mutation is, at the end of the day, that ends up being what's relevant. Now, your specific mutation matters when you want to test other people in your family, and Alana's going to talk about that a little bit later.
One other question. I'm 71 now. Up until last year, I was told to have an MRI test because I'm at high risk. And then I got kind of tired, so I asked I'm followed by a breast surgeon. And she said that I don't have to have it anymore, which I was relieved, but I don't know, is that...
So we're going to come to that a little bit later. So we've got some other things coming. I won't take away everyone's thunder for the night. We're going to have one more question, then we're going to move on, and we'll have time for other questions later, too. But go ahead. Yeah, so the pancreatic risk in terms of absolute numbers is probably one-ish at most, 1 point something percent. It's not very high. I do think we're getting better. We worry a little bit more if there's been pancreas cancer in your family. There may be specific other genetic modifiers that are specifically going with that. And I should say that for any of you that want to get down to individual level details, we'll be glad to take questions with you either offline or call the office later this week. But, and I'll get your one question in quickly.
By loss, that somehow the normal gene becomes defective and damaged?
Yeah, exactly. So even things like, for instance, I have to say I fly a lot. So when I'm up in the air, I get a lot of radiation exposure. Thankfully, hopefully you don't. But with that, then I get damage to my DNA and my cells, and that could basically cut one of my brake lines. So that's one of the things that happens to all of us just as we age. Those changes are happening. Okay, so let me turn over the program. Mary Beth Terry is a professor here in our School of Public Health, fabulous advocate for women with breast cancer, and I have to say she thinks a lot about the next generation, too. So I'm going to turn it over to her.
Thank you. And one of the real joys of being at Columbia for so many years has been to be able to collaborate with Dr. Chung. So in my brief time, I just want to give a very broad overview of what we know now about non-genetic risk factors and ways to minimize your risk. And during the question and answer and at the end with the panel discussion, I'm happy to answer more details, or feel free to email me at any time. Okay, so just to follow up with what Dr. Chung has said, the latest data on cumulative risks, and these come from very large consortia. So some of you in the audience are part of the Breast Cancer Family Registry, and we've contributed all of our data collaboratively to the BRCA1 and BRCA2 international consortia. So now we actually have the largest cohort study of BRCA1 and 2 in the world, and this allows us to make much more precise estimates about cumulative risk as well as non-genetic risk factors. And so this is the paper that Dr. Chung had just showed you. And so the main reason to show you this is that there is no cancer gene that's 100% penetrant. And that's true for all cancers. There's hundreds and hundreds of cancer genes, but none of them are 100% penetrant, which means that there's genetic modifiers as well as non-genetic modifiers. And you can see on the left for breast cancer, the cumulative risk and how it goes up with BRCA1 is about 10 years earlier on average than BRCA2. So you're going to have a shift in your breast cancer incidence if you have BRCA1 versus 2 comes about 10 years later on average. And then you can see the ovarian cancer risk for BRCA1 and 2. And as Dr. Chung mentioned, all of these papers are publicly available. Maybe we could put them on the website for those of you who want them. So just very broadly, here's kind of a summary of non-genetic risk factors for breast cancer. So most of these risk factors we know from all women who get breast cancer. And more now, there's data specifically on BRCA1 and 2 carriers. And again, most of the more precise estimates come from these large consortia, and that we benefit from all of your generosity in participating in research for that. So a couple things just to highlight, and you probably have heard about all of these risk factors, that there's some that what we would call more modifiable, if you will, such as physical activity, and there's been now a number of studies supporting that physical activity as early as adolescence may not prevent cancer, but certainly can delay the onset of cancer in high-risk women. Healthy body weight, I'll show you some data in a couple minutes. Alcohol intake, these are what we would call more modifiable risk factors. What we color in pink here would be the reproductive risk factors, and so often people say breast cancer non-genetic risk factors are not modifiable because they really do involve decisions about reproductive events that, really, except for breastfeeding, is something that we would not call a modifiable factor. But there still are a number of different modifiable risk factors, and what I put in red are risk factors that we have a little bit more data on. Again, through your generosity of participating in research, we have some exciting data that's not published yet on NSAIDs and BRCA1 and 2 carriers, but hopefully, in the next few months that will be, and we can share that with you certainly as soon as that data is published. And then as you can see, then there's other risk factors, that are stronger, such as family history, benign breast disease, and mammographic density. So what I'd like to highlight, I know there's a lot on this slide, but you probably hear a lot about relative risks and absolute risks. And these are very difficult concepts for people, even with PhDs in math, because they're very different. So a relative risk is what we refer to as a unitless measure. It's relative to something. So when we say something increases cancer 50%, that means a relative risk of 50%. That's not an absolute risk. That's a relative to some comparison group. So often when we talk about non-genetic risk factors and when you're exposed to this in the news, it's often talked in terms of relative risk, but what we all care probably most about is absolute risk. So here I'm giving you an example of what happens when you have a relatively modest risk factor. How does it affect you if you have higher absolute risk? And so even if we have a risk factor that's similar across all women, women who are at higher absolute risk because of their genetic susceptibility and family history will benefit more from modifying that risk factor. Okay, so even for a relatively modest risk factor, so a modest risk factor is 1.3, for example, and most of what I showed you on this slide, these are all very modest risk factors. Okay, they're not like smoking and lung cancer, which is a huge, large risk factor. These are modest. But modifying modest risk factors can have a big impact if you have a larger absolute risk. So this slide here is just showing kind of the effect if you're at very low risk, if you were to modify something like alcohol use or something like that, compared to someone who's at higher absolute risk. So we recently finished analyses in about 18,000 people from the Breast Cancer Family Registry, and this shows you just what the impact could be across the life of modifying a very modest risk factor. So one modest risk factor is body size, and during these years, there's actually a reverse or flipped association with body size. But as you can see, as you reach the menopausal years, women who have a stronger family history have a bigger absolute gain for modifying that non-genetic risk factor, okay? So even though we talk in terms of these relative risks for non-genetic risk factors, it's still helpful to think about your absolute risk. And if you have higher absolute risk, you actually would benefit more than someone who's at a lower absolute risk for modifying that risk factor. So I just want to show you a few slides then from the kind of the best data we have to date, which takes all the literature that's published and puts it together in one estimate. And these are what are often referred to as meta-analysis. And so there's a lot on this slide, and really all I want you to highlight, focus on is, I think with the lighting maybe it doesn't, it's not dark enough, but in the back, if you can see, it's like a pale orange. What I want you to focus on here, these are kind of the best data we have to date on BRCA1 mutation carriers. And these are the things that actually reduce the risk. And these are all relative risks, right? So you know if you're already at a higher absolute risk, these actually are more important. And so what are they? They relate to body size, they relate to tamoxifen use, they relate to age at menarche, breastfeeding, menarche. So you can see there that. Now, what I want to just highlight, though, is even though this is the most, the best data we have so far, this SR means that all they have in terms of the literature is from a single report. Okay? So when you hear the news about these non-genetic risk factors, some of them have been shown now in 50 different studies, but BRCA1 and 2 carriers, most of the data comes from single reports. And again, that's the need for participating in these studies because we get more precise estimate when we can pool our data with larger studies. And then these just show some of the things that can affect increasing risk. So it includes smoking, and then these relate to timing of pregnancies, and again, smoking. They had categorized it in a lot of different areas. This here, because this is more than just one report, is a stronger association. So where it says meta, that means that they combine data from a variety of sources. So here I just show, again, the best data that's been aggregated so far for BRCA2 carriers. And again, you can see a couple things that pop out in terms of reducing your risk. One, obviously, being tamoxifen, and then a couple that pop out in terms of increasing the risk. And again, when you see a meta as opposed to a single report, you know that there's more data out there now. So on both of these slides, what I'd like to highlight is that there's a lot of things in the middle here that basically span this estimate of 1, which means we just don't have enough data yet. So when you have very wide intervals or you have single reports, it means that we haven't had until recently the ability to make a precise estimate on these non-genetic risk factors. I'd like to just then very quickly also just show you what they found in terms of ovarian cancer risk. So again, you can see now here there's very consistent finding with oral contraceptive use in BRCA1 carriers for ovarian cancer risk. And then you can also see the breast cancer, breastfeeding rather. And then here, just to highlight for BRCA2, again, the oral contraceptive use reducing the risk in BRCA2 carriers for ovarian cancer. So where are we going with all of this? So one, probably within the next few months to a year, you'll be seeing a lot more of results from these pooled consortia for non-genetic risk factors. It's taken years to get all the different study data together, but they'll be coming out very rapidly now. I know there's at least 5 or 6 that are under review in terms of some of these non-genetic risk factors. And so what does that mean? So when you think about the BRCA1 and 2 mutation carriers, what we know about risk in BRCA1 and 2 carriers is actually relevant now for the entire world and how we think about cancer. So for the first time ever, breast cancer is really the dominant cancer on every single continent. And unlike in the US, around the world, actually you see much more of the cancer happening under 50. So here we have about 20% of breast cancer happens under 50. Globally, it's about 1/3 of all breast cancer happens under 50. And so a lot of what we learn about estrogen receptor negative cancer in young women is relevant to, for example, what's happening in India, which has a very high proportion of estrogen receptor negative cancer. And of course, what we find with families here is very relevant because even young women who are diagnosed without a family history, their girls have a family history. And so very, very quickly, because I know we have a lot else going on, this just shows you what's going on every single continent in terms of breast cancer risk for the last 30 years. So it's increasing everywhere. And so what that means, it's increasing because of environmental factors, but you have to have, again, it's an interaction between the underlying genetic susceptibility and then your environment. And in particular, what's happening in the US is a specific increase that's been happening since 1976 in women under 40. So this is not because of breast cancer screening. This is a very, it's actually 2% per year, which doesn't sound like a lot, but if any of you are economists, you know that if you compound something at 2% per year over the past 30 or 40 years, that's pretty significant. In black women, it's actually at 3% per year since 1970s, and so that's all under 40. So that's a very big difference in what's happening in the overall breast cancer. I'm going to skip this in the interest of time. And then just to tell you that where we're going now, as Dr. Chung said, is really the Breast Cancer Family Registry we've been following since the mid-90s. Their children now, we're following the girls, and we're following to look at breast development during adolescence. And so we've been following them now over the last 6 years. And a couple of things just to show you what we've been finding, which is interesting, this is work of my collaborator, Dr. Bradbury, is that girls with a breast cancer family history are actually starting to smoke earlier than girls without a breast cancer family history. And a little bit more in the drinking, but definitely you see the smoking. And so as I showed you on those slides before, smoking actually can increase your risk of cancer because, you know, it's a major carcinogen, and if you have the brakes not working, as Dr. Chung said, that is a big issue. So this information needs to get out to the next generation. And then what we've been finding, and this is just findings from the last year, is that girls with a breast cancer family history, they're actually developing breasts earlier than girls without a breast cancer family history. And girls in general are developing breasts earlier than the generation before, but this is not, in our study, not driven by being overweight. These are all girls who are average weight. So my last slide then is just to think about what it is that we really are confronting. So if this is the age incident curve of breast cancer, which Dr. Chung showed you how, most of breast cancer gets diagnosed a little later, but where all the action is happening is here. So we could still prevent and think about modifiable factors later in life, but the earlier you think about modifying some of those factors, the greater the potential is for having bigger gains in prevention. So, thank you.
We've got time for a couple of questions for Dr. Terry.
So that increase you're saying every year, so that's a factor in the fact that we have better detection mechanisms? So, I mean, is there?
Yeah, so, and actually what's,
That really seems like amazing that that's going up that much. So what are the advantages of what's causing that if it's not some noise? Whatever?
yeah, I mean, I totally agree with you. It's absolutely staggering that it's at this percent. The National Cancer Institute says anything that grows at 1% per year is an epidemic. And this, because it's specific to women under 40, cannot be explained by more screening, right? Because we don't generally screen until over 40. So this is, this is a major reason for why we are trying with Dr. Chung to do the Legacy Girl study and to figure out what's going on. But it's happening all around the world, too. Yeah.
In one of your slides, it said like incidence and mammographic density.
Yeah.
Can you go into more detail about what that meant?
Sure. So I was just reviewing kind of some of the non-genetic risk factors. So non-steroidal anti-inflammatory drugs, so that would include aspirin and ibuprofen, have been shown in observational studies to be related to reduced risk in average women. We haven't...
Would you be needing to take to actually produce some effect?
Yeah, all of those kind of studies are going on now. The only RCT that's been done of that didn't see an effect. So it still has to be shown in other kinds of settings and other kinds of evidence, and it has to be shown specifically in BRCA 1 and 2 carriers, and that's what we're doing now, right now.
And what is mammographic density?
Mammographic density actually is a measure of how dense your breasts are. So your breasts are made up of epithelial and stromal and adipose tissue, and your breast density actually changes throughout your life. So, when your breasts start developing, usually about 2 years prior to when you menstruate, but now more and more girls are developing breasts like at 8, 9, and they may not menstruate till they're 12 or 13. So there's a wider window there. And then your breasts stay pretty dense until menopause. And so the denser your breast is, that's a risk factor independent of, in terms of your breast cancer risk. So now New York State, along with a number of other states, has a law that says all women at the time that they have breast screening need to be informed if they have dense breasts. Because at the very least, it would suggest you should have alternative screening methods like sonography or MRI or something like that. Yeah. So it refers to how dense your breasts are. Yeah.
But just related to that question, so the density is an absolute concept. It's not that it makes the screening harder. It's just if you have this factor, you're more likely to have this factor.
Yeah, it's actually both. So over time, people said, well, one of the issues, particularly with premenopausal women who have very dense breasts because there's, have menstrual cycles and things like that, that you may miss detecting. But independent of that, it also increases your risk. So in now prospective studies, they've showed that independent of the lack of, the difficulty, sensitivity of detecting it, independent of that, it still is an independent risk factor. Yeah. Mm-hmm. Yeah.
Okay. Thank you very much. So we're going to let you go ahead. So we're going to move on now and get to the ovaries. So June, who is a gynecological oncologist, and she's going to talk about very specifically the things we can do for ovarian cancer and those risks.
Good evening, everyone. And I'd like to thank Dr. Chan and the team for inviting me and giving me the opportunity to come to this great forum and to speak with you guys today. I'm a GYN oncologist, Dr. Chan had mentioned, at Columbia. And today I just want to give you some updates on GYN cancer and really specifically ovarian and uterine cancer screening, and that broadly covers risk-reducing strategies for all of us. Okay, so because our time is short, I really just want to focus on three concepts. One is to kind of contradict ideas that ovarian cancer is a silent killer, because now we know more and more that there are actually high-risk symptoms that the woman cannot identify for earlier detection, which hopefully can lead to earlier diagnosis and hopefully can increase the chance of having a cure. The second thing I'd like to talk about is really kind of estimating the risk of uterine cancer. I know there's a lot of small studies as well as larger studies, and the studies can be confusing among non-BRCA mutation carriers versus a general population, women with tamoxifen versus women who are not. And I just kind of wanted to really tease out the data for you guys today. And lastly, it's really the concept that I'm talking with my patients more and more who comes to see me for risk-reducing surgeries. In younger women, the idea of oophorectomy, as Dr. Chan had mentioned, is a difficult one and not necessarily one that by the age of 40 everyone can take and who are ready for. So there is a role for removing the fallopian tube as a very relatively effective way to not replace oophorectomy, but to reduce the risk of ovarian cancer specifically for BRCA mutation carriers. Okay, so just some general concepts, and I'm not going to dwell on them too much, but ovarian cancer, epithelial ovarian cancer specifically, which is the most common type of ovarian cancer, is not necessarily the most common disease, but amongst all pelvic malignancies, it has the highest mortality of all other gynecological cancers combined. For BRCA mutation carriers, ovarian cancers can be common, and the mutations in BRCA are responsible for up to 90% of hereditary ovarian cancers. Now, BRCA mutations are not associated with an increased risk of what we call borderline tumors or tumors of low malignant potential, or what's known as mucinous ovarian cancers. But up to 22% of high-grade serous ovarian cancers, and those are the ones that are generally speaking pretty biologically aggressive, are found to be hereditary, and again, the vast majority of them are due to BRCA mutations. And how common are the BRCA mutations? Well, it's more common than I thought, actually. So it's in the general population, the incidence is anywhere between 1 out of 700 to 1 out of 900. But in the Jewish population, it can be a lot higher. So just some general information. We talked about the risk of breast cancer. I'm much more of a numbers person, so I like to see numbers written out. For ovarian cancer, and specifically, I mean, that would be inclusive of ovarian, fallopian tube, as well as peritoneal cancers. By age 70, there's about a 40 to 46% risk of developing these type of cancers with a BRCA1 mutation. For BRCA2 mutations, the cancer risk is a little bit lower for breast cancer, as well as for what we call as a whole, Mullerian cancer, which again would include ovarian, fallopian tube, and peritoneal cancers. But as everyone was saying before me, that there are other secondary cancer risks, and I actually just want to apologize for the typo. The risk of prostate cancer, and this is early onset prostate cancer, is an increased risk of about 20-fold, not necessarily 20%. But there's also a risk of skin cancer, stomach cancers, and pancreatic cancer, as we had mentioned before. Okay. So just going on the first concept that ovarian cancer is not necessarily and doesn't have to be a silent killer. Until recently, ovarian cancer was believed to be clinically asymptomatic, and that is because up to 80% of ovarian cancers are diagnosed at a later stage. But we now know that virtually all women report symptoms prior to their ovarian cancer diagnosis, and these symptoms generally happen within about a 6-month window leading up to their diagnosis. And these symptoms are generally not necessarily very specific, so they include abdominal pain, bloating, swelling, but they do occur much more frequently, about 10-fold more frequently in cancer patients. So Barbara Goff, who's a GYN oncologist out of Seattle, had followed over 2,000 patients over a cohort of years, and retrospectively as well as prospectively, she developed and she validated this ovarian cancer symptoms index. And these symptoms are significantly associated with an impending ovarian cancer diagnosis. So these symptoms include pelvic and abdominal pain, increasing abdominal size or bloating, which may be just a symptom that either the bowels are not working as well or that there's a development of ascites or malignant fluid. Patients may have difficulty eating, feeling full, early satiety as we call it. And I don't want to freak everyone out. I think that I probably myself have experienced some of these symptoms within the last month or definitely within the last year. But if you have a cohort of these symptoms that are relatively new onset, so present for less than a year, and they frequently occur, so at least 12 days out of a month, then this should definitely prompt you to at least seek advice and seek attention of your primary care providers or your OBGYN actually, so that they can go ahead and really further evaluate your risk and do some diagnostic testing and maybe some imaging. So how effective is the symptoms index? Well, it's actually about as effective as a CA-125 screening test. So as we all know, CA-125 is not necessarily the best screening test, but it's something that we generally rely on for detection and screening for ovarian cancer, even in high-risk women. But in terms of the SCOF index, the sensitivity is about 57% for early stage or stage 1-2 ovarian cancer, cancers that are limited to the ovary by itself, and about 80% for advanced stage disease with a 90% specificity. Okay. And then just going on to the uterine cancer risk. So I just want to say that, so we now know that BRCA1 mutation is associated with a small but real increased risk of what we call uterine serous cancers. So uterine cancer is the most common GYN cancers afflicting us in the United States. There's generally speaking two types. The type 1 is the most common kind. It's the one that's estrogen stimulated, and that's not what uterine serous cancer is. It's much rarer. It's not necessarily estrogen dependent, but it can be higher in incidence in BRCA1 mutation carriers. A group of researchers have followed over 1,000 women with BRCA1 or 2 mutations after their risk-reducing removal of tubes and ovaries. And what they found over a course of 6 to 10 years is that while there is no increased risk of uterine sarcoma, or like I said, the more common type of endometrial cancer, but there is a small increased risk of uterine serous cancer, specifically in BRCA1 population. For in that 1,000 cohort of BRCA mutation carriers, about 8 uterine cancer developed. The vast majority actually are uterine serous cancers, and the vast majority of those uterine serous cancers occurred in BRCA1 mutation carriers, with a risk up to age 70 about 2.6%. So, it's not that we should automatically recommend hysterectomy for patients with a BRCA1 diagnosis, but while we're discussing risk-reducing salpingo-oophorectomies with our patients, I would definitely discuss at least the risk and benefits of a hysterectomy with their surgical provider. This slide is always a little stuck. Okay. So now, not necessarily just referring to specifically BRCA1 or 2 mutation carriers, but what about women with breast cancer on tamoxifen? So while tamoxifen has an anti-estrogen effect on the breast and is commonly used to improve outcomes for women with breast cancer, it does have a modest stimulating activity on the lining of the uterus and the uterus overall. It is associated now with an increased risk of what is known as uterine polyps, uterine endometrial growth, or some of the more other benign conditions of the uterus. And now most studies have agreed that there is a very small but real increased risk of developing the more common type of uterine cancer, the endometrial cancer, for women on tamoxifen that is higher than age-matched population. That relative risk is about 2 to 3 folds. Now, those risks may be modulated by the dose of tamoxifen that you're on, 40 milligrams versus 20 milligrams a day, and it may be modified by the age of the patient and the duration of use. But there is a very slightly higher risk of endometrial cancer on tamoxifen users. Some studies have found that there is an increased risk of uterine sarcoma in patients on tamoxifen. And that is really hard to tease out because uterine sarcoma in the general population is so rare that we don't actually have or know or can dissect, intelligently what that actually means. So not to confuse the last 2 slides or so, but the bottom line is that while the BRCA mutations does not necessarily impart a risk of uterine sarcoma or endometrial cancer per se, but if the BRCA mutation carriers have a diagnosis of breast cancer, and if they're placed on tamoxifen, then there is about a 2 to 3-fold increased risk of the more common kind of uterine or endometrial cancer. But overall, the risk is pretty small and is definitely outweighed by the significant survival benefits provided by tamoxifen therapy on breast cancer patients. So actually, our society do not recommend routine surveillance for that very small increased risk of endometrial cancer for the patients. Okay. And so just going on to surgical interventions, I think the gold standard, as we all know, is what's called a prophylactic or risk-reducing BSO, standing for salpingo-oophorectomy, removing the tubes and ovaries, and that's generally recommended by age 40 or after completion of childbearing. So removing the ovaries do decrease ovarian cancer risk by up to 90%. And the reason why it is not 100% is because there is a small residual risk of what's called a peritoneal carcinoma. Depending on when you have the risk reduction surgery done, it could be as high as 10 or 11% lifetime risk in high-risk women. Removing the ovaries would also decrease subsequent breast cancer risk, especially the estrogen receptor positive ones, anywhere between 40 to 60% or so. And how common are these cancers at the time of risk-reducing surgery? About 4.4% or about 5% or so for BRCA mutation carriers undergoing this surgery. But it is a very nuanced decision, and I can have long conversations with my patients about it. There are definitely a lot of pros and cons on either side in this discussion. So, going through an oophorectomy or removing the ovaries do definitely lower the risk of ovarian and breast cancer, but it does increase the risk of hip fractures. It increases the risk of coronary heart disease that we know of, and cardiovascular disease. There's an impact on sexual function, libido, vasomotor symptoms, the hot flashes, night sweats that we generally experience, and also, as we know, an increasing risk of neurological conditions. And by that, I just mean, some women report cognitive dysfunctions, so maybe a little bit harder to remember things. Others, in longer-term studies, have found that women have a higher risk of developing not necessarily dementia, but just difficulty recalling things. Okay. The ovaries also have a small but real protective risk for colon cancer and lung cancer. And again, we talked about the improved sexual and cognitive functions. So overall, from this large cohort nurses' health study, it is found that if we can leave the ovaries in up to age 60 to 65 or so, then we should. But remember that they're not necessarily talking about the high-risk population. So I think the point of the slide is just really to acknowledge the nuance of, discussing removing the ovaries, particularly for younger women, because it has definitely real emotional, psychological, and physical effects, especially over long term. So, in light of that increased risk of removing the ovaries, there's been a lot of research focusing on maybe a less radical alternative. And around the same time, research in the lab have figured out that that high-grade serous ovarian cancer that we're talking about may actually stem from the cancer cells that lines the inside of fallopian tube called the fimbria. So these cells are called STICs, otherwise known as serous tubal intraepithelial cancer, and that's a mouthful, so I'm just going to call them STICs. These STICs on the lining of the fallopian tubes that kind of hover over the ovaries have the same genetic and genomic profile as the ovarian cancer microscopic cells that's just lying next door. And so in laboratory, they've shown this. And then also clinically, a lot of studies have found that STICs are present in BRCA mutation carriers undergoing risk reduction surgery. They're also present in ovarian cancer patients. They're present in fallopian tubes of patients with peritoneal carcinoma. So perhaps removing the STICs and removing the fallopian tube would also depart a protective risk for peritoneal cancers as well. So overall, there's been a large longitudinal study that showed that removing the fallopian tube decreases specifically high-grade serous ovarian cancer risk by up to about 2/3, specifically in high-risk populations, so women with BRCA 1 or 2 mutations. Okay. So what else goes into removing the fallopian tubes? Not that much, actually. So it's a relatively easy surgery. It takes maybe about 16 more minutes or 15 more minutes longer operating time. But more importantly, for younger women who desires to retain their fertility, we found that removing the fallopian tube, the entire fallopian tube, have not been shown to affect ovarian function or ovarian reserve on the ovaries that's adjacent to the fallopian tube. And so in thinking that removing the fallopian tube in its entirety can offer risk reduction of 2/3, and it's relatively safe and cost-effective, a lot of our societies are now recommending that just at least talk to the patients about the option of removing the fallopian tubes or bilateral salpingectomy with delayed oophorectomy as an effective interim, kind of a bridging option for especially younger women who is at a high risk for developing ovarian cancer. Okay. So this is my summary slide. I just wanted to kind of say that, ovarian cancer, is not necessarily a silent killer anymore, that increasing awareness of our own symptoms may impart an earlier diagnosis and increase the risk of cure for our patients. The BRCA1 mutation carriers do have a slightly higher risk of developing what's called uterine serous cancers, and that removing the fallopian tube is feasible, it's safe, and it's relatively cost-effective as a way for risk reduction for patients. This two-step approach, removing the fallopian tube first, followed by removing the ovaries, may be a very good alternative for especially younger patients patients who are at higher risk. Okay, and lastly, just want to putting a plug for this program that we're developing at Columbia. Dr. Trivedi, whom you'll hear from after myself, and myself, we're heading this program under the guidance with Dr. Chun. And it's a program specifically designed to, answer questions and help coordinate and streamline services for women who may be at high risk or who are at high risk for developing breast and ovarian cancer. As we all know, a lot of these women need a myriad of surveillance strategies, consultations with different physicians, from surgeons to GI doctors. So I think that the impetus for developing this program is really to help them coordinate and streamline this care, but we also provide access to clinical trials, including treatment and prevention trials. And so we think that this may be a very good opportunity, a good resource for this group of patients. Thank you. I'll take any questions. Yes.
Not all of your slides were on this thing. Some slides were duplicate and some are missing. Would they be available on the website?
Yeah, I can definitely. Or, you can feel free to reach out to me and email me. I'd be happy to send out these slides. I did do some last-minute revisions, yes.
Okay.
Yes.
Women decide to remove just the fallopian tubes. Is
Mhm.
that generally recommended to do it in the 40s and then delay oophorectomy until the 60s? Is that kind of a time frame, or?
Actually, it's a very individualized decision. So I think the standard recommendation is still to complete the oophorectomy by age 40. But, as we've seen in some of our previous presentations, especially for BRCA2 mutation carriers, that risk of ovarian cancer doesn't start to go up higher until age mid-40s or age 50s or so. So the recommendation is still the recommendation that removing the tubes and ovaries should be considered and recommended by age 40 or until completion of childbearing. But, women start to worry about the risk a lot earlier than that. And sometimes by age 40, you're still not ready to, go into surgical menopause, which is reasonable. And, with a lot of my patients, they're still not quite done with starting a family or completing a family by age 40. So I think that's where a lot of, having that option of removing the fallopian tubes in that gray zone period may be effective.
Would you recommend a self-injecting during a C-section if it's opportunistic? That's the situation.
Yeah, so, opportunistic self-injectomy for low-risk patients, for patients without, right, so for patients with higher risk for developing ovarian cancer with a genetic mutation, I've certainly have done that before. At the time of C-section, you minimize the risk of repeat anesthesia, et cetera. So I think the caveat is, as I usually explain to my patients, at the time of delivery, generally speaking, the blood flow to our body is about 50% greater. So there is a slightly higher risk of blood loss, et cetera. But in general, I think that that's a very reasonable thing to consider if, there's in the absence of emergencies or urgencies intraoperatively. Bilateral self-injectomies is not necessarily routinely recommended for low-risk women without the mutation, even though I know that in Australia and in Canada, a lot of OBGYNs are discussing that with their patients at time of any type of abdominal or laparoscopic surgeries.
What is an effective way of monitoring for uterine serous cancer?
So that's just a really good question. There's really not, unfortunately. Right, so number one, it is rare. It's about 10% of all uterine cancers. Number two, it's not necessarily associated with estrogen. So a lot of women typically do not have that abnormal bleeding or postmenopausal bleeding that women with a more common type of endometrial cancer presents with. So, a lot of it's just knowing your symptoms. If you have any sort of abnormal discharge, bleeding, any type of abdominal bloating, just be aware and just to report that to your doctor. Well, CA-125, unfortunately, is not even a very effective screening marker for ovarian cancer. For uterine serous cancers, when they get to be advanced stage, it can be a marker later on, but definitely not yet for screening purposes. Yeah.
One more question. I can't remember if it was you or the other doctor. You said something about stomach cancer and ovarian cancer. Is that
So I think
Like if you have stomach cancer, let's say maybe the lining of your stomach or something, do you get ovarian cancer from that, or does ovarian cancer cause the stomach cancer? Is there a relationship between the two?
I think, all of us are in agreement that, with some of the higher risk mutations, the genetic mutations, for example, the BRCA1, but especially the BRCA2 mutations, not only is there an increased risk for breast and ovarian cancer, but there is a host of other cancers that are less common in general population that may be more common with a BRCA2 mutation, for example. So it's not that ovarian cancer causes stomach cancer or vice versa. It's just that when we have a BRCA2 mutation, we're at higher risk in general for developing stomach cancer. Not guaranteed, but I think that, that's part of the reason why we started this program, the Hereditary Breast and Ovarian Cancer Program, because typically I would refer my patients with a BRCA2 mutation to at least a GI specialist or oncologist, at least for a consultation. So they'll take into light their family history, et cetera, and then talk to you about more of a personalized screening strategy.
Okay. Hold your questions, don't forget them. At the panel discussion, we're going to have time to come back to some things, but I know there are some people that are on a schedule. So we've got the second half of the high-risk cancer program. Meghna Trivedi is a medical oncologist. So what that means for many of you is that she treats women, especially with breast cancer, but she also spends a lot of her time making sure that they don't need her, which is on the cancer prevention side. So I'll let her take over.
Thank you so much, Dr. Chung, and thank you to all the speakers before me because you've kind of set some of the groundwork for what I'm going to talk about. So again, my name is Meghna Trivedi. I'm one of the breast oncologists here at Columbia, and I have an interest in hereditary breast and ovarian cancer. So I'm going to talk about what's new in chemo prevention. So chemo prevention is the medical risk management for people that are at high risk for different cancers. And, we've heard about the surgeries that people can have to reduce their risk, and while they're very effective, may not be for everybody, and other people may want to wait. So medical management allows for some other options for people who are not ready to go for surgery. So I'm going to spend the first half of my talk kind of talking about established chemopreventive techniques, and then I'm going to talk in the second half about some of the new strategies that are under investigation, including drugs like denosumab and then progesterone antagonists like mifepristone and ulipristal acetate. So we've seen this data from the JAMA 2017 article many times, but again, I just want to reinforce that BRCA1 and 2 mutation carriers are at a very high risk for developing breast and ovarian cancer. And we heard about some of the other cancers, but there's really this penetrance for breast and ovarian, and we would think that because the BRCA1 and 2 genes help with DNA repair, what is the reason for the penetrance for breast and ovarian cancer? And it's some of the theories are thought that it's due to sex hormone dysregulation in some of these end organ tissues, so the breasts and the ovaries. So the chemopreventive tactics that we have for this target these pathways, looking at the different sex hormones. So in general, breast cancer chemoprevention for high-risk women, which we define as breast cancer 5-year risk greater than 1.7% or a lifetime risk greater than 20%, which of course BRCA1 and 2 mutation carriers meet. There have been several large trials looking at some of these anti-estrogens, such as selective estrogen receptor modulators like tamoxifen and raloxifene, as well as aromatase inhibitors like anastrozole and exemestane. And these large studies have shown that there is a benefit with breast cancer risk reduction, anywhere from 40 to 65%. There are side effects with these medications, and so it's always a matter of risk versus benefits, of side effects balanced with the benefits in breast cancer reduction. Unfortunately, many of these trials did not include BRCA1 and 2 mutation carriers, so the use of chemoprevention as primary prevention in BRCA mutation carriers is limited. There's one study that did look at primary prevention, meaning in women who are unaffected by breast cancer and trying to use tamoxifen to try and prevent breast cancer. And this comes actually from the P1 trial, which was the first trial that was on the previous slide, looking at using tamoxifen versus placebo for risk reduction in breast cancer. And so when they looked at the data from this trial, they found of the 288 breast cancer cases in the P1 trial, 19 were BRCA mutation carriers. So they tried to look at what was the risk reduction with using tamoxifen in BRCA1 and 2 mutation carriers compared to the wild type, meaning non-mutation carriers. And so as you can see, 19 is a very, very small number, so there is some limitation from this data. But when they looked at the risk reduction, they found that it was for BRCA2 mutation carriers, there was about a 62% relative risk reduction in developing breast cancer. And this reduction was not seen in BRCA1 and 2 mutation carriers. So this is believed, the effect in BRCA2 mutation carriers is believed to be a result of kind of the biology of breast cancer tumors that develop in BRCA1 and 2 mutation carriers. So BRCA1 mutation carriers tend to develop triple negative breast cancers, which are non-hormone sensitive, whereas BRCA2 mutation carriers tend to develop hormone sensitive breast cancers. And so as tamoxifen is an anti-estrogen that blocks the effects of hormones, it's believed that may be one of the reasons why it was shown to be effective in this population. For secondary prevention, meaning decreasing the risk of another breast cancer in an affected woman, there's slightly more data looking at tamoxifen and BRCA mutation carriers. So I think as Dr. Chung explained, that BRCA mutation carriers who are diagnosed with breast cancer are at an increased risk of developing breast cancer in the opposite breast or the contralateral breast. And this risk is up to 40% in over the 10 years after their diagnosis. And this is without other risk-reducing strategies, so without oophorectomy or without chemo prevention. So taking tamoxifen has been shown in several studies to decrease the risk of developing a breast cancer in the opposite breast by about 45 to 60%. And again, this efficacy is slightly better in BRCA2 mutation carriers, again, thought to be due to the biology of cancers that develop in these patients. We also heard about oral contraceptive pills, or OCPs, to reduce the risk of ovarian cancer. In the general population, meaning all women with or without BRCA mutations, OCPs have been shown to reduce the risk of ovarian cancer in general, and it has also been shown in BRCA1 and 2 mutation carriers. So about a 45 to 60% decrease in ovarian cancer risk with the use of oral contraceptive pills in BRCA1 and 2 mutation carriers. Some of this protection is present with even 1 year of use, but increased duration of OCP is associated with a greater risk reduction. So using for increments of 10 years gives you a increased risk reduction of somewhere around 30%. However, as we also talked about, there's conflicting data on whether oral contraceptive pills have an impact on breast cancer risk. And again, the data is limited based on the types of studies and single institution studies that have been done. But in general, it seems that some studies have shown that there really is not an increase in breast cancer risk with a significant increase in breast cancer risk among BRCA1 and 2 mutation carriers who take oral contraceptive pills. And it's possible that the OCP formulations that were before 1975, which is when higher estrogen doses were used in the pills, are associated with the increased breast cancer risk, while some of the newer formulations may not have so much of an association. Okay, so now I'm going to spend some time talking about new strategies that are under investigation. So one, as we're learning about more of the pathways that go into cancer development for BRCA mutation carriers, one new pathway that's emerged is the rank ligand pathway. And so there's a rank ligand inhibitor called denosumab that I'll talk about. And again, because a lot of these tumors in cancer development are thought to be related to the sex hormones, there's also been investigation looking at progesterone receptor antagonists. Some of the drugs I talked about before for chemo prevention were estrogen receptor blockers. And so this is looking at the progesterone pathway. And this includes drugs such as mifepristone and ulipristal acetate, or UPA. So this slide shows, let me see if I can have a pointer, kind of shows the pathway of how we believe that the rank ligand pathway may lead to cancer development in BRCA mutation carriers. And so down here are the ductal cells of the breast. When they're stimulated by progesterone, which again is one of the sex hormones, they release this protein or this hormone called rank ligand. And that goes to these luminal progenitor cells, which are the cells that are thought to be the beginning of breast cancer in BRCA mutation carriers. And with that stimulation, they have the potential to develop into these basal-like tumors. So the hypothesis was, if we can block this rank ligand with an inhibitor, are we able to reduce this progression to a cancer type? to a cancer cell. And so there actually is a drug that's widely available that can block the rank ligand. This drug is called denosumab. It's actually approved for prevention of fractures in patients with osteoporosis and in patients with bone metastases from cancer. So there were several preclinical studies that have been done and show that when you block the rank ligand, you're able to decrease the proliferation of cells. And based on this data and a pilot study that was done in Australia in BRCA mutation carriers, there's actually a large international trial that's under development to see if using denosumab in every 6 months for over 5 years can reduce the risk of developing breast cancer in BRCA1 and 2 mutation carriers. So the important thing to remember about these chemoprevention trials is that they need to be very big and they take a lot of time to go through. So this is something that's still in development and will take some time for us to see the data, but the results are encouraging. Part of what's missing from this is what is the effect of denosumab on the gynecologic tissues. We know that BRCA mutation carriers are also at increased risk of developing ovarian and also uterine cancer. And so one of my colleagues, Kathy Crew, and I are actually getting very close to opening this trial, looking at a pilot study of denosumab in BRCA1 and 2 mutation carriers who are scheduled for risk-reducing salpingo-oophorectomy, and seeing what are the effects of administering denosumab in these women on their tissue, so on the tissue that's removed at the time of surgery, their fallopian tubes and their ovaries, and if they have a hysterectomy on their endometrial lining, versus women who don't receive denosumab treatment. And we're also going to look at some blood markers looking at this. So in this study, we're enrolling premenopausal women who have a BRCA1 or 2 mutation and who are scheduled for surgery. They get randomized to either the treatment arm, which is getting denosumab, or getting no denosumab treatment. And over the course of about 3 months before they go to surgery, they're either given denosumab or they're not given denosumab. And then at the time of surgery, we take a look at the tissue specimens under the microscope to see, are there changes in the proliferation rates of the ovaries, of the fallopian tubes, of the uterus lining, if that's available for us. And so we call this kind of a window of opportunity study that allows us to see, are there biomarker, tissue and serum biomarker effects of denosumab, and may help us build a foundation to see how this affects a gynecologic cancer risk as well. So this is a study that's going to be open here at Columbia, also at Cornell. We're also going to have a site at Dana-Farber and Brigham and Women's, as well as Moffitt Cancer Center in Florida, and also in Israel. There's a site at Tel Aviv and Shaim Shiva. Again, I talked about progesterone receptor antagonists. So these are drugs that block the action of progesterone. Again, the hormone progesterone is known to play a role in breast cancer development. So drugs that block the effects of progesterone have been shown to decrease the growth of breast tissue cells. So again, this is all preclinical data. For this, there are also drugs that are available. So mifepristone and UPA are drugs that block the action of progesterone. And so they're used, or at least in investigation as well, for birth control and treatment for uterine fibroids. And the thought is that these may have less side effects than anti-estrogen therapies, such as tamoxifen or a aromatase inhibitor. So we also have a trial here within NYP looking at the use of UPA and its effects on breast tissue. So this is a study being conducted by Carolyn Westhoff. There's a link on the slide if you guys have that in your handout. It's being conducted again at Weill Cornell as well as Columbia. And this is using enrolling premenopausal women between the ages of 18 and 39. So not limited to BRCA mutation carriers, really to understand the effects of this drug in the breast tissue, who get a breast MRI and then also a breast biopsy at baseline. They're randomized either to get the UPA drug or traditional oral contraceptive, and then they get a post-treatment biopsy and breast MRI, and again, see, are there biomarker changes? Are there changes in the tissue and the tissue proliferation to try and understand if this can be used for, again, a chemopreventive agent in high-risk women. So in conclusion, tamoxifen and oral contraceptive pills are chemoprevention agents that can be used in BRCA1 and 2 mutation carriers for cancer risk reduction. And there are lots of studies that are ongoing to determine if there are additional agents that may be able to reduce the cancer risk, and this includes drugs like denosumab, as well as progesterone receptor antagonist, mifepristone, and UPA. And with that, I'm happy to take any questions, and thank you guys for coming and for your attention. When we use it for bone cancer metastases, it's a dose of 120 milligrams. It's called Xgeva, and it's used in osteoporosis with every 6-month dosing as Prolia. Yeah.
I have a sister, and she lives in Belgium. She has ovarian cancer. She's been treated, and there's been some talk. She's gone to the university hospital, and they have a team there that is really focused on the ovarian cancer and prevention and what to do with it. And there's been talk about a pill that can be used in the women who had ovarian cancer, and if they take that pill on a regular basis, they would not come back. No more cancer. Have you heard about that?
So you may be talking about a PARP inhibitor, I think, which is approved for use. June could probably talk about that as well, but it is approved for use in ovarian cancer. It's in breast cancer. It just recently got approved for metastatic breast cancer, so not for prevention, but for treatment of breast cancer. But the PARP inhibitors work by, again, kind of fixing where the BRCA gene doesn't work.
So it is already...
The PARP inhibitors are in use. I think that's what you're referring to. It's not for prevention, no. Yeah. Right. Exactly.
But then I think in certain clinical trial settings, they can be used as maintenance therapy. So perhaps that's what
Yeah.
And what is it called?
A PARP inhibitor. So there's various different ones. One is olaparib, or Lynparza is the brand name. Yeah, of course. Any other questions? All right. Thank you.
Okay, so now we went from medicines, and now we're going to think about surgery. So Dr. Roshni Rao is the chief of the breast surgery program here, and she's going to be able to show us some things. And for those of you, she's got actually very up-close personal pictures to be able to give us some ideas of what she's talking about.
Thank you, Dr. Chung, and thank you to all of you for being here on the first reasonable spring day in 10 years in New York City. This is what I feel like. I just moved here from Texas, and everyone keeps reassuring me this is the worst winter in a long time, so hopefully that's the case. So the way I've structured this talk is my outline is going to be a little bit about giving you some insight into how we think as surgeons when we make decisions, the timing and the benefits. Particularly, this talk is focused on prophylactic mastectomy, so removal of the breast when it's healthy in BRCA1 and 2 carriers. I'm going to talk a little bit about the different types of mastectomy, and then I'll touch briefly on reconstruction. So as we've all seen with the improvements in genetic testing and the awareness of genetic mutations, there have been more and more patients who are diagnosed to be carriers, both when they're completely healthy and, of course, when they get cancer. Fortunately, with that, we've also had enhancements in surgical options as well as the reconstruction options. When we think about making the cut, we always want to be very thoughtful about who would benefit from an operation, when it is that we want to operate, which operation we want to do. So Dr. Terry did a great job about discussing some of the lifestyle factors, so I'm not going to go into that. And we also do know that there's some patients who, for whatever reason, even though they are carriers, will get into their 90s and never really have a cancer. So in those patients, perhaps any sort of surgical intervention would not be beneficial. We also do know that for men who are BRCA carriers, their lifetime risk of breast cancer is less than 10%, and so those men would not benefit from removal of their breast tissue just for risk reduction, since their risk tends to be quite low. When we look at several studies that have looked specifically at BRCA carriers, we know that prophylactic mastectomy does improve survival. So it reduces their chances of not only getting additional cancers, but certainly if you can do the mastectomy before they actually get a diagnosis of breast cancer, they will have improvements in survival. I'm going to close this here. I know you guys can't see it, but someone's cloud is trying to pull up here. All right, here we go. We also know that if we look at who has chosen a prophylactic mastectomy, it's typically women who are younger, less than the age of 60, who have already had a diagnosis of breast cancer and who have young children. It does decrease the risk of breast cancer by 95 to 100%. And interestingly, when we look at distress levels in these patients, the highest level of stress tends to be before they're making the decision about whether or not to have the prophylactic mastectomy. Certainly, there's some stress that comes with any operation, but about 6 months after the surgery is when the distress levels tend to be the lowest, which is important to think about when you're making these decisions. And in this era, we always have to think about cost, and prophylactic mastectomy does, in fact, save money in the long term. Not a whole lot of money, but it does save about $2,000 per year across the course of a patient's life as an alternative to screening or treatment of breast cancer should they develop it. So I don't know. Let me close this. It's showing a cloud. Stop the timer.
Sorry.
All right, perfect. Thank you. No, we're not advancing. Hold on. Okay, perfect. So timing is everything, and I'm often asked by my patients, especially when they're diagnosed at a very young age in their 20s, when should they consider having their breast removed? And whenever we think about timing, we do indeed know the perfect time. It's just different for every single person. So that's important to keep in mind. Screening, we know, should start 10 years prior to the youngest relative or at age 30, whichever one comes first. One of the things that's a bit of a quandary as far as identifying the perfect time is that there is some debate amongst the physicians about exactly when should you offer these surgeries. Is it better to offer the surgery when the patients are at highest risk of breast cancer, or should you try and do it a few years before their highest risk? And if you're going to make those decisions, then you have to know exactly when and how long it takes for an abnormal cell to become a cancer. There does not seem to be a whole lot of benefit to doing these surgeries for women once they're greater than the age of 60. It is generally accepted that if your age is greater than 18, once your childbearing is complete, if you're otherwise healthy and can tolerate an operation, those are the patients who would most benefit. So now I'm going to shift gears a little bit and talk a little bit about which operation we should do. I always like to start with describing the first report of breast cancer. It comes to us from the Edwin Smith Papyrus in 1600 BC. So the Egyptians actually tell us about treating these quote-unquote ulcers of the breast with a fire drill. And what a fire drill was a very long stone. They stuck it in a fire, and they stuck it on the woman's breast. And they concluded from this that this cancer was not curable. Fortunately, we've come a very long way, and one of the things that most people are familiar with, what we've been doing since the 80s, is a standard total mastectomy or a simple mastectomy. When we do a simple mastectomy, we remove the entire a large paddle of skin, we remove the nipple and the areola, and we remove all of the breast tissue. This is a picture of one of my own patients. She had a reduction in the past and then had a breast cancer and chose to have both breasts removed and had radiation on the right-hand side, which is why you can see that little bit of coloration. And she did not want any reconstruction, and this suited her lifestyle. So this is not for all women. It can be very traumatic to go from having breasts to looking like this, but this is what a standard mastectomy would look like for most people. I'm often asked, well, what exactly do you remove with a mastectomy? How do you know when to stop? We use what we call anatomic margins whenever we whenever we do a mastectomy. We go all the way up to the clavicle or to the collarbone because you do in fact have a few breast cells all the way up to here. We go medially to the sternum here. Laterally, we go to a muscle called the latissimus muscle, and we can actually see that during the operation. And inferiorly, along the bottom, we go to what we call the inframammary fold, or right where your underwire would hit. So you need to remove all of those boundaries if you're going to do a mastectomy and really get 95-99% of all the breast tissue out. In the 1990s, there became a big interest in what we call skin-sparing mastectomy. So that's when we remove the nipple and the areola, but we preserve what we call the skin envelope. So we leave all of that natural skin there. And what that does is it allows our plastic surgeon colleagues to just focus on the projection, on just getting more of that volume rather than worrying about having to take skin from anywhere else. And I'm going to show you why that's beneficial here. So first, this is a standard mastectomy with reconstruction. So she had the mastectomy on that left side and then came in later and had a flap from her belly brought up there. So you can see there's a little bit of patchiness because everyone's abdominal skin is a little bit lighter tone than the rest of your skin, and that's a reconstructed nipple. But she doesn't have a lot of her own native skin on that breast, which is why it looks a little bit funny. Having said that, once she puts on her bra or puts on a swimsuit, most people would not be able to tell. Subsequently, with the skin-sparing mastectomy, we're able to do the same operation, and here you can see on the left-hand side, because we preserved all of her own skin, the incision is a little bit more hidden, and they're able to reconstruct that nipple and the areola, so it's not nearly as obvious, and also it drapes a little bit better because it is her own skin, it's in a more natural position. This is one of my patients who, this is just about 10 days or so after surgery with the abdominal flap, and you can see she has not had her nipple and areola done, keeping in mind that breast reconstruction is always a process. But again, once she puts on her bra, and actually most of these patients don't need to wear a bra anymore because everything kind of stays where we put it, most people would not be able to tell. The plastic surgeons are able to either surgically put in a nipple and tattoo on an areola, or now there are actually a lot of 3D tattoos. This is someone who told me that she never thought she would have a tattoo, but that's a 3D tattoo on the right, and she decided that when she was getting a tattoo, she was going to go big or go home. So you can see that right there. A skin-sparing mastectomy, there are initially concerns about it, but subsequently most studies have shown that if it's done by someone who does a lot of them, you actually don't leave a lot of actual breast tissue. This is one of our own studies where we found that for most patients, less than 2% of the time do we leave any residual breast tissue, and even in patients who have cancer, we don't leave any cancer behind. Nipple-sparing mastectomy started becoming more popular in the past decade or so. Initially, there was a lot of resistance to nipple-sparing mastectomy because some of the original studies where we had done mastectomy showed that 58% of the time there was cancer within the nipple itself. So there wasn't a lot of excitement about it for a long time. But subsequently, since we're identifying folks with cancer at earlier stages, and because of the interest in removing healthy breasts, there became more of an interest in nipple-sparing mastectomy. This is a much more technically demanding operation. So this is someone, again, who is in the process of reconstruction. She's had a nipple-sparing mastectomy and just has her expanders in place right now. So this is her own nipple here, and the incision is not visible. It's along kind of where the underwire would hit there, but it's not visible for most people. This is afterwards once we place the final implants, and again, you can see a pretty good cosmetic result with her own nipple and areola. She had just gone sunbathing, so the whiteness there is not my fault. But again, once you wear a swimsuit or something like that, no one would be able to tell. You do lose the sensation at the nipple. Nipple-sparing mastectomy in BRCA carriers has been studied pretty extensively now, and it's shown to be pretty safe. Most patients do not develop cancers afterwards, as long as you're able to take a little piece of tissue behind the nipple and make sure that there's no problems with it. We now perform what's called a receiver-assisted and optimized nipple-sparing mastectomy, where we use a very long camera with a flexible tip, which helps us get around the tissue and get around kind of the curvature of the breast. And this is one of my own patients, and she's lying back, and you can see that incision kind of on the side. Again, not readily visible, but we're still able to remove all of the tissue that we need to be removing. So briefly on reconstruction, generally there are two options for reconstruction: expanders, where they place the temporary balloon, stretch the skin, and then take you back to put in the final implants, or when they use your own tissue, which are longer operations. With expanders, most people think that you have to come in every few weeks and get saline into it, which is the most common approach. Now, one of my partners, Dr. Asherman, is able to offer a CO2 cartridge with an expander in it, so you're able to get a little remote control and you can do your own expansion at home, which is much more comfortable and much easier for most patients, especially for people who come from far away. So in conclusion, prophylactic mastectomy in patients at increased risk of breast cancer due to genetic mutations is effective. It saves money. It has good cosmetic results. You have to really individualize the procedure in regards to timing, the benefit to that specific person, the type of operation, and certainly the reconstruction. Thank you.
I just wanted to share, I actually work here at Columbia. 2.5 years ago, I had all of it done. I'm BRCA2, I have no cancer, had no cancer. My mother passed away, she's the only one that had the cancer at 44. I had the prophylactic mastectomy done, Dr. Feldman, and I had the dream team, as they say, and I had the oophorectomy and the deep flap, and everything was very familiar. And I don't regret one thing. I am the people that work here, Dr. Chung, everybody that has been remarkable. But out of the 7 of my siblings, 4 of us have that gene now. So they all come here, and we're just trying to get more information. Me and my sister have both gone through, the surgeries, but I feel blessed. And if anybody has any personal questions they want to ask me afterwards, I'd be happy to just say how I felt about it. It was a 14-hour surgery. It wasn't pretty. It wasn't pretty after it either. It was a very hard recovery, but it was, when you say the stress level comes down, I worried from 15 years old when my mother died that I would get breast cancer. Now I had a reason at 52 to do something. I did it, and I feel fantastic. So
that's great.
Just wanted to
with the nipple sparing mastectomy, what is the sensation that you are left with, or can be left with?
Yeah, most women do lose sensation just because we get really close behind that nipple.
Is it cut all the way around the areola,
No.
or just part,
No,
so that
then
you keep sensation on top, what's the latter?
No, part of it is difficult because, the incision itself is down here. So we don't make any incisions around the areola at all. It's just that the sensation of the nipple is very different for every woman. Some women, it comes through the breast. So once you remove the breast, it's gone. Some women are able to retain it, especially if their sensation just happens to come from here down to here. So.
I've been fortunate and been able to retain most of it, not all of it, and did it over almost 10 years ago.
That's good.
I was a little disappointed in the surgery not being offered 60 years and older.
I didn't say it wasn't offered. So what they do is that they do all sorts of statistical analysis to see who would benefit as far as survival and cost and things. And greater than 60 is where it gets a little bit fuzzy. So I'm not saying we wouldn't offer it. I can tell you right now that I know 90-year-olds who could kick my butt. And so, I mean, I think you have to, again, individualize it. Yeah.
She did it at 52.
Yeah.
If she was a little bit later and procrastinated or whatever, and didn't do it to 62, are they going to look down on her and say, "You're 62"?
Yeah, I mean
that's the feeling that I get, because there's a few other things, like with some of the insurance companies, after a certain age, they don't even want to bother to cover pap smear.
Yeah. Well, I completely share your disdain for insurance companies, I can assure you. I think, and that's what the data shows. Having said that, again, you have to individualize it for every single patient and what their life expectancy and health and outcome is going to
Is
be.
it different from BRCA1 and BRCA2 because of the way they roll over the curve? Diminishes with time,
yeah.
A little bit, whereas the BRCA2
Absolutely.
is more likely to if they play the statistic change.
Yeah, because the BRCA ones are obviously earlier diagnosis, where the BRCA twos are later, and
So just, this is solely based on actuarials at this point.
Markov modeling, in fact, not even actuarial.
So, and what the individual person, patient might pursue, doesn't matter.
Yeah, unfortunately, it does not. I have not had any insurance company say no to a BRCA carrier who I thought was appropriate for a prophylactic mastectomy, at whatever age. So that has not been the situation. Yeah. Maybe one more. Yeah.
As far as implants, do you have to remove them every 2 years, or are they permanent? Like, what is it?
Yeah, that's a good question. So what we used to do, let me come over here. So what we used to do is the plastic surgery societies originally had told people that they should get their implants changed every 10 years. And the reason for that is because at the 10-year mark, there's about a 25% rate of perforation of rupture. But that's based on implants that we placed in the 1970s. So is it really fair to take that data and apply it to the implants that we're placing now? No, absolutely not, because implants that we're placing now, technology is better, the materials are better. So now what most people are saying is that if you don't have a problem with the implants, it's fine. You don't have to get them replaced every 10 years.
Using MRI as an indicator to every 2 years, but as an indicator of MRI,
Not-
change in the implant?
No, there's no protocols to routinely follow people with implants with MRIs. You generally can tell if they're ruptures, and in fact, all implants have what we call a hypoechoic line. So they have 3 lines that we can see on ultrasound, and we can tell just based on ultrasound whether something's ruptured. Yeah.
Okay, so we're going to round out. Alana Levinson is one of our fabulous genetic counselors, and she's going to help us in terms of sharing this information with our families. I know sometimes this can be stressful, so she's going to give us some pointers. And then after she finishes, you've got one last chance to get all of us all over again. So if you've got any questions we didn't get to.
So I'm definitely going to shift gears. No numbers, no risk curves. We're going to talk about how to share information with your family members. And this is actually a big topic, and I actually had a lot of difficulty getting it down into my 10 or 12 minutes. Every family is different in terms of family dynamics, personality, shared experiences. So I don't think there's any one-size-fits-all approach on how to share information with your family. So what I'm going to be sharing with you today is really a foundation, a framework upon which I think you can build and personalize for your own family as you see fit. I also want to recognize that many of you have probably already navigated this path. You've been on the sharing side of the information or maybe the receiving end of this information as well. And in many ways are much more experienced and experts in this than we are. So before diving right into the how to share information, I want to touch briefly upon the who and the why and the when to share information. So in terms of who, for family, we often in genetics think of family in terms of degree of relation to us. So our first degree relatives being parents, children, and siblings. These are people who are genetically and usually emotionally closest to us. And these are family members who have a 50% chance of having the same BRCA mutation that you have, and therefore the most relevant and pertinent people to share this information with. However, second-degree relatives and third-degree relatives also have a chance of having this BRCA mutation and are also important. And of course, significant others who are usually not genetically related to us, but obviously emotionally supportive. So why share genetic results? And we know that sharing genetic results with family members allows for family members an opportunity to seek or sometimes not seek genetic testing and to make informed decisions about their medical management based on their genetic test results. Sharing information can also be helpful from an emotional standpoint in terms of giving or receiving support, perhaps in relation to treatment or prevention options that you've chosen. So when to share genetic information, and this is always a big question that patients have in genetic counseling sessions with us. We in genetics advocate that genetic testing or genetic information be shared with family members when it's at a time when they can pursue genetic testing. So this is after the age of 18. Also at a point when people can use their genetic test results to help make medical management decisions. So for women at age 25 or 30, like Dr. Rao was saying, is a time that if they're BRCA positive, increased breast cancer surveillance would start. Men have a little bit more time to play with, but by 35, we definitely encourage breast awareness, and prostate cancer screening would begin at about 45. And of course, this information might also be shared at an earlier point if it might be used in reproductive decision making. That being said, a lot of the literature in the genetic counseling world around this shows that most parents share their BRCA results with family members shortly after receiving them, usually within 2 weeks. And this is even to underage children. And this is shown to strengthen family relationships and cohesion, open lines of communication. It can help explain to children upcoming related diagnoses or procedures that someone is going through. We know that children are perceptive. And so if there are multiple trips to a doctor, if children hear parents whispering, in the other room, they can often create a reality for themselves, which is much more dire or scary than actually what the truth might be. So I think sharing BRCA results helps to put it into some context. Sharing results in a developmentally appropriate way for children can also help them assimilate the risk over the period of their childhood. It can be woven into educational opportunities about genetics and also shown to help with health behavior modifications, such as smoking cessation or maybe choosing oral contraceptives as a birth control method and getting the added benefit of the risk reduction for ovarian cancer. Now, finally, how to share results. So I'm going to share with you a model that was proposed by Dr. Daly and her colleagues at Fox Chase Cancer Center in Philadelphia. This was published in 2001. And what she and her group did was took a model, a 6-step strategy that was developed initially for sharing medical information, and they adapted it to sharing specifically genetic information. And the first 2 steps are very much in the planning phase. So thinking about who in the family would most benefit from learning this information, thinking about how you want to communicate that information. Is it going to be by phone, in person, by email? And in what setting? Is it at Thanksgiving time, or do you not want it at all attached to a holiday? And also thinking about how much your family members know. Do they know that you've had genetic testing and they're waiting by the phone to hear the results? Or is this information going to come completely out of the blue? Also think about how much they want to know. And in every family, it seems that there are people who are information seekers, who are going to eagerly jump with this information and have their genetic testing done the next week, and other people who do not want to hear a word about this. And so it might help to anticipate maybe what some of the reactions from these family members might be, and ask for a clear invitation to disclose this information to them. When you share your genetic test results, it's so important to share with them the actual gene and the specific mutation. If you can bring your genetic test results with you, have them in hand, your family members are going to need that when they come to genetics, if they're going to do testing, so that we know exactly what mutation to test them for. You might want to share with them how you have used these results, and explain to them what their risk of also having this mutation is. And then responding to feelings. And we know that there is a range of emotions that family members can have in learning this information. It might, again, help to maybe anticipate this, be supportive of family members, and come with resources and support for them so they can go through this process as well in learning. Some additional hints are you might consider involving a neutral third party. So maybe this is a family friend or your favorite genetic counselor. And as much as possible, try to provide information in what we say a neutral rather than a directive way. So for example, you might say, I was tested and I have my results. Are you interested in learning this? Instead of, look, I have this mutation and you need to go right now and get tested. And of course, there's family members who don't want to talk, who don't want this information. That can be a very hard place to be in. We have to remember that everybody uses this information or doesn't use the information in their own way. So we have to be respectful of that. Be supportive. And if at some point you're yourself feeling upset by this, take care of yourself in this process. And be prepared to seek support for yourself if you're feeling this. And finally, I just want to share a few resources which I think are helpful. The first being with FORCE, and we're fortunate to have FORCE with us today. FORCE is a great group. They have a lot of information on their website around talking with your family. For example, this worksheet, which definitely helps in the planning phase of thinking about who and what and when to share information. For those who are social media fans, KinTalk is a web-based platform which allows you to upload your genetic information, your family history, and electronically invite your family members to see this information. And they also have a discussion board for BRCA carriers. And the family letter template is another resource that we have. I think you have some samples in your folders and maybe on the resource table as well. This is a template that's written. You can personalize it, put your family member's name in, and send it to them. Has information about your mutation, what the BRCA gene does, and resources if they want to follow up on that. And finally, a paper that I found recently published, which I really wanted to share with you in more detail, but there's just not enough time. But it involves communicating genetic test results with children and with a developmental approach. And it really breaks down children from preschool age up to emerging adults, so 18 to 25, and provides resources and guidance in terms of how to share the information in an age-appropriate manner. I believe these other links and websites are in your resources. And finally, I want to remind you that we're always here. Dr. Chung, myself, and my colleagues, we're always here if you need anything, any resources, any support. We're here. Thank you.
Any questions for Alana?
If an immediate family member or sibling does not want to be tested, but I would want my niece, for example, to be tested, given the mom has a family history also.
Yeah.
Do you think insurance would cover that because we bypassed the parent?
Absolutely. Yeah. Yep. Usually at least to third-degree relatives, so it'd be to your cousins, your nieces, your second-degree relatives. Yeah.
Okay.
Crystal color.
I guess relating to that question, how would you go about telling someone else's basically child about this if they don't want to scare them and share this information with them?
Yeah, that's a good question, and I was actually anticipating that question. That's hard, right? Because it's not unusual. You kind of we tell our siblings, and we hope that our siblings are then going to share that with their children, and it's not unusual that that doesn't happen. And I don't have a perfect response for you. I know some patients worry that it's going to damage their relationship with a sibling if they're going to their niece or nephew, for example. Does anyone have any words of wisdom in terms of that? It can be a difficult situation to navigate, I think. Yeah.
Well, it was an awkward situation in my family. I have 2 sisters and a brother, and my cousin and I both are BRCA2 carriers, we have exactly the same little number with the, whatever it is, code. And it turns out that there are other people, there are other cousins, there were all these great grandmothers, and it's like, holy crap, this is really real. And I determined that I inherited this from my father, who his sister is my cousin's mother, and I shared this with my siblings with, I thought, and not a, leaning one way or the other, not urging them, whatever, just saying, here's this information, do what you want to with it. I know from one sister, she was tested and found to be negative. I've never heard what the other two did. It's none of my business. And yet I constantly think about their children. And I feel like I have done due diligence by telling them, and what they do is up to them.
Mm-hmm.
And I really can't do anything more than share that information. And I met with a genetic counselor here at that time, and she, I cannot remember her name, but she was wonderful. It was extremely helpful, and it just made all the difference in the world. So whoever you were, thank you.
Okay, so we're going to open it up for questions at large, and one thing that I'll say is in your packet is an evaluation sheet. I see a couple people have it already. If you don't mind, we really want feedback. This is the first time we've done this. I can't promise we did everything right, but we do like to hear what you liked, what you didn't like, what you'd like to hear more of, less of. But we're thinking about doing this on an annual basis, or at least more frequently. Do we need to put these?
No, that's fine. Leave them right where they are, please.
Okay, very good. So do fill that out before you leave and drop them at the front desk. But I want to open it up now that you've heard everything. Were there questions about things either we talked about, things we didn't talk about, and we still have questions about? Go ahead.
This is sort of a general question. You have a strong family history on both sides of the family, and you suspect maybe you have a mutation. Should you go about getting tested for your physician? Should you come to a genetic counselor?
Yeah. So I'll say we geared this tonight, just so people know, we geared this mainly for people who knew already that they had BRCA one or two mutations. If there are folks who don't have mutations, or in case there's someone who had testing before and didn't have a mutation identified, one of the things I'll say is there are other genes besides BRCA1 and 2, more and more genes that we can test at this point. This is something that for the most part needs to be ordered by a physician. Doesn't have to be a genetics doctor per se, although we and the genetic counselors know a lot about this, but can be ordered by a variety of physicians. For those of you who have heard about this, I'll let you know so you can tell your friends at the next cocktail party. If you go to 23andMe trying to get the BRCA1 and 2 test, it works if you're Jewish, and it doesn't work basically if you're not Jewish. So if you're not Jewish, it is not the test you want to take. And at this point, you do need to go through one of your doctors. Again, the number's up here if we can help you in terms of doing that, but any of your other doctors can also order that testing for you. Boy, lots of questions.
Mine's just a quick housekeeping issue. You mentioned that we could email you, Dr. How is it?
Oh, yes.
Oh, I'm sorry.
That's okay, the easy way.
Where can we get your email addresses?
If you go, as you're checking out, we'll make sure we'll have people there to help you with any of the contact information for any of us up here. So, in the back.
So what I found this session really helpful, and I'm happy to hear you're going to do more. What I found personally really confusing, so I have the BRCA2 gene, and I discovered it by a complete fluke. My cousin went and got genetically tested, and she told me about it, and I happened to do it. She was negative, and I was positive. And it was right after I had my first child, so I was emotionally a mess. So it was really confusing to me to navigate through all of the doctors and how to get information. And I came here ultimately through, I ended up through my OBGYN figuring out what doctors to work with, and I was lucky in that he has a really good network and he kind of point him in the right direction. But either now or in the future, for patients who discover that they do have a gene mutation, is there a program, and I think you referenced one, where you have this mutation and there's kind of a guide of here are the steps, and even through the screening process, it seems like if you get in a group of good doctors, then you're screened on a regular basis and you're sort of guided along the way. But at least at first in my experience, it was figuring out what doctor to use and how to connect them, and you're essentially keeping up with your own calendar and making those appointments and chasing
So I think we actually showed this up, and again, we'll have the contact information. The point is you can get your one-stop shopping. It's really, we're showing you who we are in part, so you get a sense of really who your doctors could be in terms of that. This is the dream team. Someone made that, use that. So these are the doctors that can help you. If for some reason you didn't like one of us, we have other doctors on the
Yeah, so when somebody gets that, you all have set that up. Is that okay? And
that's available for anyone. If you have friends, family, whatever in the area.
Yeah, and I think your story and similar stories such as such as yours really serve, like I said, as an impetus for Dr. Trivedi and I, and of course under guidance with Dr. Chun, we wanted to provide this service more. We have a patient navigator that can help you coordinate all these appointments. And so that's really the kind of program that would be beneficial for yourself. Just a note that we don't replace the genetic doctors or the counselors, but we do help to streamline access to all of the appointments and all of the doctors, so that it's just a little bit less stress on your plate. Yeah.
I have I'm an 11-year ovarian cancer survivor treated here. I'm doing really well, thanks to the team. Quick question, I have a daughter who's also positive. When I became ill, I was about 53 years old, so relatively young. I'm BRCA2. And of course, there was no question about telling the kids. They knew that there, what was going on. We did benefit. I think they benefited from learning early on and sort of, working with me along with my long recovery. But at any rate, my eldest daughter is about to be 30 and she's single and she's BRCA2 positive. She's worried about her fertility and what her options are at this point. Could she come to your team to get counseling and ideas of what her options are, egg freezing, whatever the salivectomy or whichever the tumor was? Is that something that's...
Yeah, absolutely. I mean, we do have a reproductive endocrinologist from our Department of OBGYN who's specifically interested in cancer fertility, oncofertility, or providing services to younger women such as your daughter. So as I always say to my patients, she's very young. It seems like the risk of cancer at this age is quite low, but earlier access, just thinking about it and discussing it earlier always helps in terms of these decision makings, which should happen over the course of time, not rush into things.
Is that contact going to be available out there?
Yeah, so I will definitely email out my contact information, including my slides, to anyone who wants it. But at the last slide, we have a website, and then and we have a phone number for anyone who's interested.
And I have one quick comment, and that is, I don't know if you're going to ever address this. It's more about advocacy, in that I feel, and I have a group of friends who have been through similar situations with the transition from gynecology into oncology, where the medical practitioners seem to know how to do that. They might suspect there's a problem. They chalk it up to fibroids or whatever because of the problem with being able to detect ovarian cancer, for instance. They sometimes err on the side of, well, it's probably just a fibroid. I've heard this over and over again. It took me about a year to get diagnosed through about a year of symptoms. I'm just wondering if you had any comments, any of you, if you've noticed that there is that kind of gap in care that patients are having.
Well, I'll just say, and I think all of you are here for this reason, you're your own best advocate, right? I mean, you know your body best, you know when something feels off and feels wrong, and you just have to be able to put that forward and have a good relationship with one of your doctors. It doesn't have to even be all of them, to be quite frank, who's willing to listen to you and be able to work with you. So, and just keep pushing, right? If you feel like something's wrong with your body, let someone know.
Yeah, I'm going to repeat my question about the MRI recommendations, or is it like individualized?
Well, go ahead. I mean, we'll talk about gender.
I'm at risk. My mother and one of her sisters died of breast cancer in their 40s, 50s. I have some, I guess, second-degree relatives who are positive. I'm 71. I have not had a diagnosis of breast and ovarian cancer. Actually, I have all my internal GYN organs removed in different surgery while I was at it. But I was getting the breast MRIs, which I thought were a pain in the neck, for me. And I asked my breast surgeon who follows me, because I'm high risk with exams and so on. And I asked her, do I need to continue the MRIs given that I'm 71? And she said no, but when I went to NYU, to their program, Freya Schnabel said yes.
We'll let the breast team
Yeah.
answer this.
Yeah. So some of that is very individualized. I would look at the mammogram, see what your density is, because the density, as Dr. Terry was talking about, as we age, your breast tissue becomes more and more fat replaced, and fat on a mammogram looks black. So if you're looking for a cancer, many times it can be white or bright white calcifications. So if you have a lot of density, it's hard for us to see those cancers. And in those patients, we know that getting the MRI is very beneficial. For people who no longer have that density, if it's all just kind of black, it's much easier for us to see things. And in those patients, perhaps they don't need the MRI. Especially now, we can do 3D mammography, which can pick up a lot of things that we weren't able to do otherwise. So, you'd really have to look at someone's mammogram, look at their actual life expectancy and their overall health to figure out if the MRI is helpful or not.
Now, did I understand correctly that you have sort of a program just for somebody like me who wants sort of like a second opinion, if you wish, and have it all in one place to discuss my options, how I should be, what my surveillance should be, and so on?
Yep, absolutely. So when you want to come out of the, and I just want to make sure I'm right, stop by the desk on your way out, and we've got contact numbers for you.
We're actually going to email everyone, all the attendees today, with the contact information and all the details, anything you need. Also, go to our website, the Columbia BRCA1 and 2 conference.org, and give us any questions, and we'll definitely respond to them.
Thank you.
I guess this would be for Dr. Rao. Would you be able to speak to reconstruction options when it comes to upper body exercise and kind of the contraindications when it comes to that?
Yeah, so as far as the reconstruction goes, and I did some research on this as well, because there's a lot of concern about the latissimus flaps, where we remove that muscle kind of in the back and do a reconstruction based on that. And was there going to be some weakness or some inability to do yoga or real Pilates, things like that? And actually that does not seem to be the case in most women who are doing most activities. Even with expanders and implants, you're able to do most of the activities that you normally would. Now there is a certain period of kind of deconditioning, if you will, after any major operation. So one of the things that I like to do is for someone, especially if they're having the abdominal flaps, is to put them into almost like a prehab, is what we call it, where we have you start boot camp or whatever it is to get the rest of your abs really good and strong, get those arms good and strong, and then have the surgery so the deconditioning is lessened. But in the long term, there do not seem to be any significant impact on your ability to do normal activities and even normal exercise.
So push-ups, pull-ups,
Yeah,
everything?
perfectly fine, yeah.
So I have a daughter, she's 7 years old, and she has a BRCA1. So I just wanted to see how you see the future, like 20 years from now, like what's developing now, and how do you see prevention, 10 or 15 years from now?
I mean, I think that's a great question. I think all of us are trying to work towards new advances. We have, like I mentioned, there's a lot of interest in chemo prevention and ways to kind of delay some of these surgeries and the toxicity and morbidity that comes with some of these surgeries. So I think, our hope is these studies take a long time to conduct, and so hopefully with some of these window of opportunity trials where we can develop foundation and looking at biomarkers to try and expedite some of these studies, I hope that we'll have some better chemo prevention and probably improvements in surgical techniques and things like that.
Yeah, it's hard to tell. So from my perspective, I'm hopeful that in 20 years I will be out of a job because they'll found, and I can go to my second why I moved to New York. I want to be a backup Broadway dancer, but I'm hopeful that we'll just be able to do a little injection of something and I'll replace all the bad genes with good genes and we'll move on. Yeah.
I think my dream would be to come up with like as I think Dr. Chan had referred this to, like, there's a lot of talk about liquid biopsies with patients, a liquid biopsy. So it's just a blood test for patients who was already diagnosed with a certain type of cancer, but in remission. And then in that period of surveillance, that has been shown to be very decently good in terms of picking up circulating tumor cells that might be too early to detect on a CAT scan or clinically, But that's for patients who's already had a cancer diagnosis. We're definitely not, even in high-risk women, moved that up to a screening scenario yet. But it would be wonderful, and I know that I'm in touch with a company that's doing this type of research to kind of develop that testing platform, screening test platform that's more precise and and specific for the type of cancer that you're worried about.
Then you get, that you have the tumor cell, but then there are a few things that you can do before you really have the cancer develop. Like,
Yeah, so I think, prevention, detection, treatment, and prevention are kind of the three things that we look for. And obviously, the ideal is to prevent cancer from happening before. Even with intensive screening, you're still catching an early cancer, which is, of course, a good thing. But if there's a way that we can get to preventing it, especially in women that we know that are high risk, I think that's all of our dream. We'd all be out of a job, but that would be great.
Two questions. One is follow up on that, the potential for the screening test for women at risk, or men at risk for that matter. How soon is that? And the other is colon cancer in BRCA 1 or 2. When I first was diagnosed, and there was a precaution to have colonoscopy every 3 years, and then it went to 5, and where's that at now? And I'm BRCA 1, but there would be an increased risk for BRCA 2 probably.
So I'll just say generally in terms of that, there's not a huge risk in terms of colon cancer. So in terms of if there's, and we can go over on the sidebar in terms of your family history if there's any reason to do anything differently. But I think generally following you should still get colonoscopies, but following the regular guidelines.
Of course, they age you out at a certain point, but you fight.
Right. And just remind me your first question, because now I've forgotten.
I think you were referring to
the liquid biopsy.
The optimistic time frame for developing that biopsy. It's definitely also not ready for prime time just yet. I think the difficulty with validating screening types of screening type of blood tests is that you're basically screening for relatively rare cancers in a larger cohort of women. So these studies and validations do take some time. I would probably expect in the next 7 to 10 years, that would be like a very rough guesstimate.
What about gene splicing therapy, CAR T and stuff like that? Is that likely to happen?
So gene therapy is not completely pie in the sky. I'm not saying for BRCA 1 and 2, but there are other genetic diseases that literally we're running clinical trials across the street in the Children's Hospital for certain gene replacement and gene therapy. So I think the main thing I would say to your 7-year-old daughter is you can't believe what life is going to look like 20 years from now when it comes to medicine in general. So I think the main thing is just make her grow up to be a secure, confident, well-adjusted child. And if you can accomplish that as a parent, we'll take care of the rest of it.
In your opinion, a traditional mammography with sonogram, is that as effective as screening as with 3D?
So mammography, so first of all, mammography is, in every well-done study, mammography improves mortality. There's no doubt about that. So there's a lot of controversy about when to start and how much and everything. There's no doubt that mammograms save lives. So let me put that out there first. Then after that, we can have the conversations about what age you should start, how often you should get it. The 3D mammograms do pick up about 10% more breast cancers. Mammograms do miss a certain percentage of cancer. They miss about 15%, so they're not perfect. So that's when we have to look at someone's actual risk, for BRCA 1 and 2 carriers, and then decide would they benefit from MRI as well, or if they're not a gene carrier but just have a family history, should we do mammogram alternating with ultrasound, or should we do 3D mammograms alone if their risk's just a little bit higher, then maybe once a year that's enough. I would recommend that there's been no study that shows that 3D mammogram is hurtful. So I think at a minimum, 3D mammography is probably where we're all going to end up in a few years as far as a standard. The addition of ultrasound we do based on that individual person's risk.
I have a question, there's also a question in that corner.
Oh, good, thank you. We'll go here and then we'll go here.
I have a question, and I think this was alluded to in one of the slides, sort of why they acknowledge that the prevalence of the BRCA mutations is higher in the Jewish population. I'm wondering, I know that there's been some talk that, maybe other racial ethnic groups are being just under-tested, and I'm wondering about that and if there's any move to try and motivate testing or screening in other populations.
Yeah, so I'll blow your minds, or maybe for some of you. There's a movement afoot actually to do population-based screening, really of both BRCA1 and 2, some of the hereditary colon cancer genes, and actually some of the genes that cause heart attacks. So the cost has come down tremendously. So to give you some sense, any one of you, if you wanted to, could go out and get a $250 or less genetic test for the genes we've talked about and then some. And that's tremendously different. When we did this a decade ago, for instance, the cost was $3,600. So there's been a lot that we've done in terms of improving access, and you're right that we have many underserved communities that aren't getting access to this, and there's some other difficulties interpreting the results, which we are dealing with. But yes, the movement is afoot to be able to get it to more people, to be able to allow them to understand their risk better and to do something about it.
And is there any knowledge about emerging, greater prevalence in other groups?
There are definitely pockets around the world, and there are pockets because of what we call founder mutations, so certain mutations that are specific to those communities. I don't think we've saturated and found all of them yet, but there are also ones that are specific to one single family. So we have to sort of balance this and make sure that we do testing right. Okay, your question, I'm sorry.
I just wanted to ask, for someone that's BRCA1 positive, when it comes to reconstruction, opting for implants, does it put them place them at a greater risk for the cancer to retire?
No. No, it doesn't. Whether the reconstruction, and we get that's a great question. There were some concerns about that initially, about should you just do the mastectomy and not do reconstruction? Will it make the cancer come back? Will it make it harder to detect and all those things? All of that's found to be not true. So regardless of the reconstruction, they're totally safe, and it does not increase the risk of the cancer coming back or of it being harder to find.
So the implants doesn't come with a percentage of cancer risk?
Breast cancer or any cancer?
Well, the implants causing a certain cancer.
Yeah, so there is, so I think what you're referring to is that there is an implant-associated lymphoma. So that is very, and I think it made a lot of headlines, including the New York Times a few years ago. So there is a specific type of implant that is associated with a very specific type of lymphoma. That implant is what we call a textured implant, and the risk of that is extremely, extremely low. You have a greater chance of getting into a car accident driving down the Hudson than you would of getting that lymphoma, even if you have that implant. But if you do the smooth implants, that risk is not there. So.
Is there a chance of reoccurrence of breast cancer on the breast wall or the chest wall after mastectomy?
Yes, because a mastectomy, like I showed you with that, when we go to all of those anatomic landmarks, we cannot remove 100% of all your breast tissue unless we remove all the skin from here to here, and we just don't do that. So we do leave behind probably about 1 to 2% of your breast tissue in most experienced hands. So there is.
What kind of preventive testing can be done?
Yeah, so that breast tissue that's left behind, that 1 to 2%, most of the time is in that tissue immediately behind the skin. So we don't do mammograms, we don't do MRIs. The way that it would show up as a recurrence is almost like an insect bite or a pimple. So that's what we're looking for. So if you've had a mastectomy and you see something like that, that's what we worry about. It wouldn't show up behind, per se, behind the reconstruction. It would show up within that skin paddle because that's where the breast tissue is left.
Would it show up in a PET scan?
The lower limit of PET scans is generally about 5 millimeters. So generally something has to be bigger than 5 millimeters before you can pick it up on a PET scan, but you can see something on your skin at that size. So.
So just to go along with what Dr. Rao said, so while we don't do routine mammograms or MRI or ultrasound in patients who've had mastectomy, we do strongly recommend every 6-month clinical breast exam. So following either with your breast surgeon, your gynecologist, your oncologist, coming in to get checked every 6 months just to make sure that the chest wall looks good.
Okay, last question.
Thank you all, first of all, so much for taking the time to share your knowledge. My question is, I think for Dr. Rao, you mentioned that, of course, the rates of survival are improved by getting preventative mastectomy. But my question is, can you compare the rates of survival for those women with women who do early detection, screening, and then treatment?
Yes, so for BRCA carriers specifically, yeah. So for BRCA carriers specifically, we know that improves the preventive strategies are much more likely to improve survival. Part of that is driven by the fact that, as Dr. Trivedi mentioned, if you're a BRCA1 carrier, you're much more likely to present with a triple-negative breast cancer. So while that's certainly curable, it's harder. So most of the time, if you're in these screening programs, we do identify the cancers early, generally stage 0 or stage 1, but that's not quite the same as preventing it as altogether. So that's why when you do those analyses, and they've done analyses of the different strategies, the prophylactic mastectomy has the best survival, even compared to enhanced surveillance.
Thank you.
Okay, one last question.
You said insurance covers the genetic testing and prophylactic surgeries. Does it cover in vitro once you know that you're a carrier of these mutations and you want to make sure that your children do not inherit your mutations?
So very briefly, we didn't touch upon this. Alana did just peripherally. So there are some young women who would say, I want to have children, I want to make sure I don't pass this down to the next generation, I want to prune my family tree. Insurance will not cover that. So insurance in terms of in vitro fertilization, at least in this country at this time, will cover it for infertility. Very, very rarely, even for diseases much, much, to me, more severe than BRCA 1 and 2, they won't even cover it for the most part. So if you have problems with fertility, they may cover in vitro fertilization for fertility. You may pay out of pocket for the genetic testing for what we call pre-implantation genetic diagnosis, but generally it is not covered in this country. Okay, so on that note, again, thank you all for coming out. Please do give us feedback, and thank you so much for our speakers. And feel free to grab any of us after.
Thank you.